and symptoms recur, then let me repeat the endoscopy. No, don't do that. Repeating the endoscopy need only in a couple of situations. Number one, we have a regular reflux patients, but all of a sudden now there are, alarm symptoms. Yeah, that's something else. Or patient with biopsy-prone Barrett. Then we repeat the endoscopy. If no dysplasia, 3 to 5 years, not very often. Or patient with very severe erosive esophagitis. This is a patient with Barrett esophagus, a long Barrett. We use Prague classification, of course. We take 4-quadrant biopsies every 2 centimeters. If there is no dysplasia, since this is a long one, we repeat the endoscopy every 3 years. If we believe that this patient has been taken the enough number of biopsies. Or, very rarely, we have cancer in the presence of Barrett. In my database, we have more than 9,000 reflux patients. This is the only one with cancer. Only one. My dear friends, in our countries, in global south countries, you, us, and many other countries, Arab countries, but whatever, we are pretty safe with the Barrett-related cancer, because this is one of the studies we published. When we look at the whole endoscopic findings, esophagitis exists in 1/3 of patients only. And remember, majority of them has esophagitis LAA. And as I mentioned previously, LAA, we do not count it as a part of the reflux spectrum anymore. In that case, only few patients have B, C, or D esophagitis. And also, Barrett is about 1% only. I'm talking about biopsy-prone Barrett, intestinal metaplasia inside the esophagus, only 1%. It's different than the global north countries. Their prevalence is somewhere around 6 to 10%. But not. And if there is no Barrett, there would be no Barrett. No need to, repeat the endoscopy again and again. Recurrence of symptoms are not an indication for endoscopy, because as a characteristic of the reflux disease, when you stop the proton pump inhibitor therapy, in 6 months, 80% of your patients will come back with symptoms. This is a chronic disease. You cannot cure it with PPI. How about the others? This is achalasia. Unfortunately, that's one of the, we perform a study, we look at the more than 300 achalasia patients. Diagnostic delay, even in Turkey, because we have many multi centers, is about 4.5 years. We ask them, how many doctors you have seen before us? The median number is 4. People miss and miss and miss achalasia. Whom you think an achalasia patient with predominant dysphagia and do not respond to PPI therapy from the beginning, even the double dose of PPI. And then, since if you can find a way to refer to the motility, that's fine, it's the gold standard. Otherwise, I will mention that, go with time barium swallow. This is another interesting case. About 10 years ago, I used to call that there is no eosinophilic esophagitis in Turkey. Now it's as common as reflux disease in my practice. Today, I have seen 2 cases. You see the rings here, furrows here, edema here, and I cannot pass by the regular scope. I stop it, and I came back with a pediatric scope, and I took the biopsies. Who are those patients? Young patients. They may define, not necessarily, but allergic background. And then we take the biopsies from distal and proximal esophagus. All the patients with dysphagia must undergo to the endoscopy, and the biopsies must be taken from those patients, distal and proximal part of the esophagus, and count with the eosinophils by your pathologist. If there are more than 15 eosinophils, this is EOE, eosinophilic esophagitis, and the therapeutic approach is completely different. Okay, ambulatory 24-hour esophageal pH impedance monitoring. Of course, this is a joke. That's me. Actually, I got the anti-reflux surgery. I'm so happy with the surgery now, but that's what we have. Who needs 24-hour pH impedance monitoring indications? Of course, confirming the diagnosis. But as I said, if you have a patient responding to PPI, who cares? That's reflux disease. But unresponsive to PPI with the typical symptoms, of course, we need this. We do not use pH only. All the surgical candidates must go for motility and pH impedance. Not, rarely, I see patients with achalasia or scleroderma with a wrong diagnosis. They went to the surgery. That's a disaster. And also, if PPI non-response, first of all, we perform without PPI. We call it off PPI monitoring. If we detect a pathologic acid exposure, then we repeat on PPI while patient taking the PPI. What are the possibilities? We still see persistent acid reflux because of fast PPI metabolizer, which is pretty common, at least in my country, number one. Number two, still remember, PPIs do not decrease the number of reflux episodes, okay? This is pretty important. Because PPIs actually change the nature of reflux state from acid reflux to weak acid or non-acid reflux. That's crucial part. In that case, we perform a 24-hour pH impedance on PPI, and we evaluate the patient's symptoms. If the patient still has a symptom reflux relationship with weak acid or with non-acid reflux, okay, this is something else. They don't need the PPI anymore. We go with alginate, we go with surgery, we go with other things. Okay, that's important. And also reflex hypersensitivity and functional heartburn. Those are very important two phenotypes. Reflex hypersensitivity means that particular patient, this off PPI measurement, that has normal acid exposure. And when the patient feels the symptom, patient press the button, symptom button, and the software check whether for this particular symptom there is a reflux episode or not. Even with the normal acid exposure, if there is a correlation between the reflux episodes and the patient's symptoms, then we call it hypersensitivity. Patient feels the normal. This is reflex hypersensitivity. In that case, we use more a neuromodulator, namely amitriptyline or nortriptyline. I love those medications. Low dose of neuromodulator, such as 10 milligram of amitriptyline, at least for 2 months. But we are supposed to explain the patients, why we are putting the patient on a medication labeled antidepressants, because patient, oh, I'm not crazy. This doctor is crazy. I'm not taking this medication. This is a risk. And the worst scenario, functional heartburn. Those patients have normal endoscopy, normal acid exposure. When they feel the reflux symptoms, they press the button, but there is no reflux episodes during their symptom. There is no correlation between reflux episodes and symptoms. I say their brain is burning, not the esophagus. No correlation at all. Those are the nightmare group. That's really a functional problem. It's not a reflux problem by itself. And I will come back that one, but their psychiatric comorbidity is much higher than the other phenotypes. How about the other atypical symptoms? Yeah, you can use it, but still there's a low diagnostic yield in this group, even though many global north guidelines, American guidelines, suggest 24-hour pH impedance to all the patients with suspected extraesophageal symptoms. Come on, that's not practical at all. Instead, we suggest high dose of PPI and high dose of alginate combination in such group and put them on 2 to 3 months and see the symptoms and also refer to ENT. The step impedance pH catheter, you see there are 1 or 2 pH measurements. There are rings. I do not have time to go through details, but this system, as I said, measure acidic reflux, weak acidic reflux, and non-acidic reflux. And also, patient press the button. This is the pH part of it. Patient press the button, reflux episode, press the button, reflux episode. All of them fits with reflux except this one. Patient press the button, but there is no reflux episode here. You see, there is a correlation, dear friends, between the symptoms and reflux episodes in this particular patient. Okay? And another example. But here, what we detect that patient pressed the button 22 times. 19 of them was related with symptoms. Then, and acid exposure is normal. Then that patient has reflux hypersensitivity. Then we treat them. If they respond to PPI, that's okay. But if they don't respond to PPI, then we treat them with neuromodulator. But this is an interesting one. Patient pressed the button 26 times. Only one of them was related with reflux. This is functional heartburn. You cannot treat them with PPI, possibly neuromodulator, convincing the patient and ask for the psychiatric comorbidities. Okay, this is how we treat them. Okay, another technology, we call it capsule pH monitoring. There is an attachment here. This is the capsule. During the endoscopy room, under the sedation, you don't need motility here. Otherwise, you need motility in order to put a pH impedance catheter under the, but that's a blinded procedure. After you detect the place of the electrode, you apply this, apply a suction sucks the mucosa inside the capsule. When you press the button, there's a needle passing by the mucosa and fix the capsule inside the esophagus. And you take the applicator out. There is no catheter, nothing. The system transmits the pH data to the receiver, and it stays there for days. 1, 2, 3, 4, 5, whatever. You can also use that. Superiority, there is no catheter. Problems, more expensive than catheter-based technologies. And also, this technology cannot measure weak acid or non-acid reflux. I love it, actually, if I tell the truth. If that will be a cheap technology, I would put all the patient, if I find nothing during the endoscopy, I immediately put this one. This is how it looks like, one of my patients. I'm not going to go to details of reflux disease, but there are some management approach, of course, lifestyle changes. Lifestyle means smoking, alcohol, and weight loss. Those are the 3 major stuff. Others, it's up to the patient. No, don't push them a lot. In terms of the therapies, I do not believe antacids. Alginase, prokinetics, yeah, maybe. H2 blockers, yeah, maybe. Proton pump inhibitors, those are the best medications for that inhibition. As endoscopic therapies, there are some arms and others. Nowadays, they are abusing by many people. And of course, anti-reflux therapies. Weight loss is the best one, of course, in terms of the therapy, and they improve a lot. This is an alginate. We wrote the largest alginate paper ever, published in Turkish Journal of Gastroenterology. Currently, we are updating it. 31 pages of 37 pages of alginate. It's a big one. Alginate produce a raft here. You see the raft here. Okay, and protects against the refluxate going all the way up. If there's a reflux occur, alginate goes up first, cover the esophagus, and protect the gastric content touching the esophageal epithelia. I love this medication. It's nearly non-absorbable. Best medication for pregnancy, best medication during the lactation period. Very good medication for the mild reflux patients, and we use a lot in combination with PPI. such as, in severe patients or patients with LPR or laryngopharyngeal reflux disease or chronic cough. And as I said, we combine it. I don't use antacids. I don't use that much H2 blockers because there is a tachyphylaxis at the level of receptors in 50% of patients. But prokinetics, whom I use prokinetics in patients with overlapping with gastroparesis or overlapping with dyspepsia, then I use prokinetics and PPI both together. I love the combination, by the way. As I mentioned, this is one of the study we just published a couple of months ago in Journal of Gastroenterology and Hepatology, I believe. We look at the different PPI response in different phenotypes. You can see here, you can see here, there are, here, I'm looking, by the way, questions. Please, guys, ask some questions, okay? I'm looking forward for your question. There's only one question. I'm going to answer it at the end. And the PPI response is different in right-hand side of the slide in patients with esophageal hypersensitivity and functional heartburn. Aerosol esophagitis gives the best response with PPI. I love of that group. And remember, PPIs are currently the gold standard medication for acid inhibition. This is a very interesting slide. I'm a part of the ROM group, Turkish representative in ROM Foundation. We look at the clinical relevant psychological distress and or somatic symptoms in many countries. Highest level of clinical relevant anxiety, depression, and somatization. Actually, the world record goes to Egypt, followed by Turkey. And I do believe in your country, it's also high. About 1/3 of my patients in Turkey has somatization disorder. And about 55 to 60% of patients in Turkey and Egypt has one of those. That means for all functional GI disorders are pretty much related with psychiatric comorbidities. This is not a psychiatric disorder, but psychiatric comorbidity is crucial. This is why we performed this study for a while ago, published in Diabetes and Science, and you see nearly all the psychiatric disorders are pretty common in different reflux phenotype, specifically in functional heartburn and esophageal hypersensitivity. They are pretty common problems. Then when we evaluate a patient, we are also supposed to think about the psychiatric comorbidities because esophageal hypervigilance is important and that reduces quality of life in such patients. And belching. I see a lot of belching patients. Supposedly they have reflux problem. No. Please remember, isolated belching is absolutely a psychiatric disorder. They keep belching and they keep belching. Generally they have introvert personality and they express their personality with that way. There are good questions, but with your permission, I'm going to respond at the end. I'm going to show you two different algorithms. One is primary health care. If we have a patient with heartburn and regurgitation or regurgitation and respond to therapeutic trial, and if there's alarm symptom, of course, patient goes to upper GI endoscopy. Otherwise, check the symptom severity. If mild, go with lifestyle changes, on-demand therapy with alginate, H2 blocker, or low dose of PPI. No need to put all the PPI on standard dose. There is a general rule all around the world. Put them on standard dose. Come on, guys. If patient responds well to the half dose of PPI, keep them half dose. If no, then give standard dose. Or if patients moderate or severe, then give them double dose. This is a step-in type of approach. Or very severe symptoms, combine with alginate or prokinetics, as I mentioned. Then continue with minimum effective dose. Or that's a very complicated algorithm. If you have a difficult patient and if you are lucky and you have the different diagnostics in a patient, then you perform 24-hour pH impedance and diagnose the patients if there is any reflux hypersensitivity, functional heartburn, weak or non-acid reflux, whatever. This is also another approach. If your patient does not respond to PPI therapy, unfortunately, one of the possibilities to put the patient on this difficult diagnostics. HB and reflux disease. This is our problem, global South countries. What we assume that there is no relationship between a Helicobacter pylori and reflux disease. Eradication might increase, that's debatable, possibly increase the Barrett esophagus and distal adenoid cancer of those patients, even that's debatable. And eradication should be performed, if your patient will be on PPI therapy continuously in order to get rid of the atrophic gastritis. Otherwise, it has no value on those patients. Okay, let's come to the motility a little bit. This is a normal high-resolution manometry, upper sphincter, lower sphincter, a lovely swallow. And this is a typical achalasia one. You see, high-resolution manometry is the gold standard technology for achalasia diagnosis. Those are the indications for motility, of course. Achalasia, spastic disorders, ineffective disorders. Also, I love to use them in rheumatologic disorders. Of course, before the surgery, it's a must. Bariatric surgery, if there is a complication afterwards. Systemic motility disorders such as Menkes syndrome and others, also we use it. Please remember, before the placing of pH impedance electrode, you must have an motility. There is no place for pull-through or any other technique. We are supposed to perform motility first. Afterwards, we put pH electrode. This is how it looks like. This is the upper sphincter. This is the lower sphincter. As 5 ml wet to swallow is coming down, proximal esophagus, transitional zone, distal esophagus. And this is the high power, this is the low power, oceans to very high mountains, okay? And, deserts and others. This is the catheter. But it's difficult to see it that way. This is why we move it to spatiotemporal plots, and we are looking that way. This is exactly the same swallow pattern here, but that's more easy to see what's going on. And this is one of my patients. You see a lovely normal one, upper sphincter, striated muscle, smooth muscle, opening of esophagogastric junction consists of LES and diaphragm. You see this opening, okay? There are different metrics. I'm not going to go to the details of that, but then we measure it, that. According to this, Chicago classification version 4.0 defined the diseases with the relaxation, means the relaxation of this esophagogastric junction. If there is a pathologic relaxation, then we diagnose the patient's achalasia type 1, 2, 3, or esophagogastric junction outflow obstruction, such as this one. You see, this is a megaesophagus. This is how it looks like in the motility. Swallow, nose, no peristalsis. Such a big esophagus, catheter cannot detect any peristaltic activity. And EGJ is always closed. Esophagogastric junction, never open. This is type 1, late achalasia. How should I treat them? That's an ongoing debate. It depends which one you can do the best. Pneumatic dilatation, hilar myotomy with DOR, or with POEM. I have the best guys around. Generally, I send them to the POEM because my POEM guy is lovely. And this type 2 is the early phase of achalasia. Esophagus not dilated that heavily. There's a panosophageal pressurization. Since it's the early phase, studies show that results are pretty the same. But again, you can either perform pneumatic dilatation or surgery but laparoscopic surgery. I don't want to send anyone to the open surgery because, or if you have a good POEM guy, go with POEM guy. Unfortunately, we have a lot of bad POEM guys. That's a bad thing, to send them. They cut short, or they're afraid of cutting well the muscles, then patient immediately comes back. And this is type 3 achalasia. This is the difficult one in order to separate from the others. Type 3 achalasia easily mimic esophagogastric junction outflow obstruction or jackhammer esophagus or others. This is why you need an experienced motility guy. Okay? It's not just you buy the equipment, you put the catheter and you measure it. Life is not that much easy. I'm going to mention that, but motility is a diagnostic. It's like just a picture, okay? It's not everything. Jackhammer esophagus, this is the hypercontractility. Patient comes with a very bad and severe chest pain in many patients. Esophagus contracts deadly. And this is also a problem, but we can easily refer this patient sometimes for some calcium channel blockers, nitrates, or sometimes for POEM and others. Ineffective motility, we see it in many patients. Sorry for that. That comes with reflux patients, or it can be seen even in healthy people. But if there's a bad contractile reserve, those are bad candidates for anti-reflux surgery. This is why, in order to exclude achalasia, sick neuroderma, or ineffective or absent contractility, we do need motility before anti-reflux surgery. And remember, HRM is a diagnostic tool only, and that changed a lot. And you need, in some patients, of course, you need endoscopy, or if you're a patient with severe dysphagia, you need time barium swallow. We combine all of those, we listen to the patient, then we diagnose the patient. And last points, EndoPhilip, that's a new technology, pushing a lot by the Americans. That's the promising device, but complementary device that measure the expanding function of the sphincter's hollow organs, okay? Luminal geometry or biomechanical properties. For LES, for body, upper sphincter, difficult, pylorus, anal sphincter. You can measure and then you see something like that. This is the motility. This is the Philip planometry. And supposedly you diagnose all of those. Yeah, it may help you in order to measure the distension of the esophagus, but please remember, high-resolution manometry currently is the gold standard, not the Philip. My friend, least but none last, that's an important point. We are different. We are different. We are from Global South. What is Global South? Global South is a part of geographical difference, but mainly formerly use developing or underdeveloped countries. But as I said in the opening of my talk, who is deciding about the level of development? This is mainly a humiliating terminology. Okay, this geopolitical and socioeconomic term reflects the developmental status, historical experience of colonialism, as you very well know that, and political identity. But here we should remember that we are different and we need our own association. This is why now we have Global South Gastroenterology Association. Currently, there are 30 countries, starting from all the way there, Pakistan, Uzbekistan, Turkmenistan, Kazakhstan, Azerbaijan, Turkey, and from the Africa, Kenya, Nigeria, South Africa, Egypt, Saudi Arabia, many Arab countries, Algeria, Morocco, Libya, and blah, 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 all those 30 countries. And we are organizing some meetings, and the new one is coming, 27th of August. We are going to start with a very good motility program in the afternoon. You see the program, and simultaneously intestinal ultrasound and capsule endoscopy, 3 workshops running together. For 28 and 29, we are going to discuss our realities. Barrett esophagus in non-Western populations. Okay, PCAPs, should we really do something? Test and treat for the HP with limited endoscopy access. You know, other congresses such as UGW or others, I have a huge respect, of course, and I attend those, but they do not cover our realities. Here, we are covering our realities with also case discussion sessions can be seen here. Please join the meeting. Put in your calendar, talk with the industry, talk with the drug companies, okay, and try to attend this meeting. We would love to have you there. This is my team. We are doing too many research projects all together. We all focus only functional GI disorders, reflux disease, incontinence, constipation. We have a big biofeedback program also. If you would love to come and work with us, you are always welcome. Please send me an email. And this is our reflux team. As I said, we have more than 9,000 patients in our files, GI, ENT, pulmonary medicine, general surgery, psychiatry, and pediatrics. Also, we have a pelvic study group as well. This is my email. This is my phone number. Or you are always welcome to come and work with us. Again, please try to join us. Thank you very much. Now, let me respond few questions. There are some lovely questions, I think. Okay. Ahmed Mohammed and Maligui think that I don't agree with that. LAA has not been counted as reflux disease. May I ask why Japanese have modified LA with grade M added to further address minor mucosal changes of reflux disease? This is a lovely question. Yes, this is that used to be a big debate with the grade M, but grade M and grade A, I do believe, even though I'm not a fan of the global North studies, I do believe that because I see many LAAs. We used to perform a healthy volunteer study. We had many patients in this study. In doing this healthy volunteer, we have seen many LAAs as well. And the public-wide studies show that 8 to 10% of healthy volunteers have LAA. Plus, they might have silent reflux disease, but if we count all the LAAs, then we will be in trouble because this is going to increase the number of patients tremendously. Here the question comes, okay, then I don't have any sophisticated equipments. Let's be more pragmatic. At least you can say that LAA might give you a little bit clue. That is maybe possible. Okay, but currently it's not accepted, I can tell you. If borderline acid exposure time like 4.1%, but upright acid exposure is high, while other adjuvant parameters are negative, could we consider this patient is non-pathological acid reflux? That's a good question. This patient is in the gray zone. In that case, I tend to look at, for example, baseline impedance. I assume this is pH impedance study. I love that metric, baseline impedance metric, but upright 7.1, for example, is high. The question is, who cares? Treat it like the reflux patients. Also, please look at the symptom reflux association in those patients. If you detect an association, still treat like reflux patients. Oh, check. A potassium channel blockers, Prosans of and reflux disease. Oh, yes. I don't know if you guys have Prosans in Algeria. Currently, we do not have in Turkey, but I'm following those very closely. If I have it, I use it. They are more potent. They are better in some aspects, such as severe reflux disease or such as HP eradication. We have only two problems. Number one is the cost. It's high cost. Number two, still we do not know long-term results with that. Okay. What else? Sometimes patients have pathological reflux, yet negative SAP and SI. Yes, you are right. Sometimes really, Mona, hi Mona, how are you? Mona from Cairo. And yes, but in that case, still we assume patient has reflux disease. But possibly will respond well to neuromodulators and go with the PPIs in those patients. Okay, Imad, that's all. No more question. You can take the stage and close the session.
Yeah, I have some questions, if you permit, dear Professor Serhat.
Go ahead.
My question is about arms. What is your experience about arms in treating reflux disease?
ARMA and ARMS, first of all, if they have a place, which is debatable, they should be performed following objective reflux testing. In Turkey, for example, there are some people abusing it. Bad halitosis, they perform ARMA. I've seen a lady, 17 years old, because of halitosis. She undergone to the ARMA. And the studies are pretty conflicting. Long-term results, I think, will fail since it's very easy to do so. People love to do it, but we do not know the long-term results, okay? And without the objective confirmation test, I cannot support ARMA and ARMS. And even we have everything in my center, we prefer to use currently other research based on technologies such as Gerdix and others. But we all hate ARMA and ARMS, if I tell the truth. But I know many people love it, but we do need long-term results.
Dear Dr. Serhat, it's Mona Adda again. I'm going to ask about the same question regarding the positive pathological acid reflux, yet negative SAP and SI. Does this mean that this patient may have an overlapping functional heartburn with pathological acid reflux, since both heartburn and regurgitation are negative?
Yeah, you are saying that
because I cannot.
Yeah, go ahead, Mona.
Because we do not have the luxury of doing both in Egypt because it's very costly. So does this, I assume that when I thought of it in that, okay, there's pathological acid reflux at the time being, yet this is why AAT is high and the Mr. score is high. Yet, since there is negative symptom correlation with a big number of symptoms, there may be an overlapping functional disorder. So would you suggest to go?
To go with what, Mona?
With dual suppressing the acid and neuromodulators or psychiatric consultation?
But this is the problem is the other way around here, because here, if patient would have both positive SAP and SI, that means there's a reflux hypersensitivity. And in that case, this patient is a better candidate for neuromodulator therapy. But if both are negative, yeah, you may say that, but here I'd rather to look at the pathologic acid exposure. If your catheter is in the correct place, okay, I'm not talking about you, but in some centers they don't perform motility before the catheter, and in that case, I'd rather to treat the patients exactly with the non-erosive reflux disease as a NERD patient.
Okay, thank you. It's always a pleasure to meet you.
Yeah, always. Thank you, Mona. Imad?
Yes, second question, dear Professor. What do you think about the indications of pH, impedance symmetry, and high resolution manometry, is it most common in your units? And which are the indications, the most frequent indications of both?
Yeah, we have a lot of equipments. We have currently 4 motility equipments and I don't know 7 or 8 pH impedance equipments. We always have a very busy schedule. And one of my technicians dedicate for upper, or 2 technicians, and 2 dedicate for lower GI technologies. And the most common is actually, of course, pre-measurement for reflux surgery. Number 1. Number 2, atypical symptoms of reflux disease or patient with PPI unresponsive ones. Also, we see some patients with the asthma or recurrent asthma or chronic cough patients. Also, we perform those. In terms of the motility and also bariatric surgery, because if there's a severe reflux disease, unfortunately in obese patients, bariatric surgery should move to the bypass, but not the sleeve. This is a big drawback for the sleeve gastrectomy. And in terms of the motility, of course, dysphagia is the number 1. We have tons of achalasia, some esophagogastric junction outflow obstructions, some chest pains, and a lot of connective tissue disorder. We have a close relationship with rheumatology, and funny enough, a couple of patients a year, we see the changes at the manometry. Patient doesn't know because of rheumatological disorder, and we refer to the rheumatologist saying that this esophagus has rheumatologic changes. Please check the patient for connective tissue disorder. This is also another indication from my side.
Last question, dear professor. How about the learning curve of higher resolution manometry? Is it easy to perform it?
Performing is easy. The ideal way is to buy the equipment first. If you don't have enough money, you can buy a high-resolution water perfusion manometry because solid states are more expensive, although water perfusion's cost for transducer and capillaries are pretty high. And making not a big deal. Just you are putting a catheter and following the Chicago protocol. It's easy. The problem actually in 2 places. Number 1, troubleshooting. Sometimes you lose channels. Sometimes you don't know how to deal with the systems. But more importantly, motility is an instant picture of the esophagus. You are supposed to understand the management of the patient with motility, with patient symptoms, motility, endoscopy, time barium swallow, or maybe esophageal biopsies for eosinophilic esophagitis patients. This is the combination of everything. For example, we have a friend now from Egypt. We have too many visitors. Oh, he's here. Hi, Ahmad. And we have too many visitors here. Our main idea is, we give them the catheter, we show them how to perform the procedure, but more importantly, we discuss the management protocol in order to combination on everything. Learning curve, yeah, what you should do, buy the equipment, suffer by yourself for 10, 20, 30 cases, then visit one of the good center and learn the details and start doing by yourself. Okay, this is how you should do. But if you want to continue, because there are many dead equipments all around Turkey, and at least they buy the equipments, then the guy who learned it left it, leave the department, then the equipment just stay there. Those are pretty expensive equipments though.
Thanks. And other question about poem in achalasia. You told us that there are some good poem endoscopies and bad poem endoscopies. You reveal fear of cutting the muscle, and you
Yes,
reveal other problems in poem. Could you explain more, please?
of course. we see many failed poems. I'm working with I think one of the number one or number two poem guy in the country. He's so good. But we see a lot of failed poem. First of all, this shortcut, they say, I'm cutting very short. This is a big mistake. We see many recurrence after that shortcut, 3 centimeter, 4 centimeter. First of all, actually, without motility, if there is no very dilated esophagus, I show a picture of the time barium swallow. If there's a very wide esophagus, that's okay. But otherwise, you need experienced motility guys in order to diagnose the achalasia. We also see many wrong diagnoses because patients rely on numbers. They don't know what is the motility. They only look at the numbers. IRP is 17. This is achalasia. Come on. You don't know what you are doing. Okay? This is, as I said, this is a full package. Everything should be included. Afterwards, you need good hands. You are supposed to go and learn from the best hands. For example, I have never done poem because I'm working with the best poem guy. Why I'm supposed to do that? Then you need, because we perform at least how many? At least 5 to 10 patients a week with poem. And he has the best experience. But if you perform poem once or twice a month, don't do it. Don't do it because your learning curve will fail.
Okay, dear Professor Serhat, we arrive at the end of this great meeting. So very nice presentation. Thank you very much, dear Professor.
Thank you.
Yeah, very nice presentation, very nice informations. So we have changed some informations about motility, and thanks to the audience. Last thing, do you want to say something, Professor?
Yeah, please join us in our Istanbul meeting. We'd love to have more Algerians, also Egyptians. They are here. And please come and join us in our Istanbul meeting, 27th to 29th of August. We should support our own realities and our own meetings as Global South countries.
Yeah, sure. I invite my friends to Istanbul this August. It will be a nice opportunity to enhance our network. So thank all of you
Thank
to
you.
be with us this evening, and see you soon.
Thank you.
Goodbye.
Bye-bye.
Bye-bye, Professor. Bye-bye, dear friends. See you soon.